things thrown. Like, I'm going to kill you, I'm going to do so-and-so. Or they'll make comments about your appearance. I mean, they'll just talk about your clothes, the way you look, things that can be very provocative if it were another patient, and you don't really respond to it. And I think that's one reason why psychiatrists give some people the creeps, is because they have a very flat face. They don't respond a lot because they're used to observing as kind of that clinical approach, and we're used to kind of interacting with and connecting with. And if you try to connect with everything a psychiatric patient gives to you when they're in a forward manic state or forwardly schizophrenic, you might actually bite off more than you can deal with. So just you have to see it and deal with it. You'll get there. Okay, let's look at some other stuff here. Of course, the bipolar 1 disorder. When does it happen? As I said, you know, this 18, 19, 20, 21. It's not that important, except that it's earlier in life. First onsets can occur throughout the life cycle, so you could be 60 or 70 when you have a manic attack, which would be, I think, scary for people who knew them all their life. More than 90% who have a single manic episode go on to have a recurrent mood episode. So that one manic attack and then done can happen, but it's the minority of the people. 60% of manic episodes occur immediately before a major depressive episode. So you can see that over half the people who have mania are eventually going to come down. How can you not sleep for days on end and not just crash? I mean, just completely neurotransmitter-wise just crash, and they will do that. Individuals with type bipolar 1 who have mood episodes, multiples within a year, that 4 or more, are rapid cyclers. This is just an example, just to show you what you can see here. Euthymia, that's normal, quote-unquote normal. They go to depression and then have a manic episode. As soon, if they just have this, if you saw this person at this point, you know, in their life, you would diagnose them with major depressive disorder, okay, their depression. But that would be a misdiagnosis, because in life they're actually going to end up being bipolar 1. Because after they have this episode, if that's all you see in their life, that diagnosis is correct for what you know. But in their total brain derangement, you know what's wrong. See, they come back to mania, and as soon as they hit mania, then at this point they're bipolar 1, and they remain bipolar 1 forever. So their record will probably have major depressive disorder, you know, 2017. Then as soon as you get to 2019, they might be bipolar 1, and then bipolar 1 diagnosis trumps major depressive disorder. So they will be considered, their record will be from that point forward bipolar disorder with episodes of depression that they have had. Does that make sense? So it's very often to misdiagnose a bipolar 1 patient, because the first presentation is depression. That's how you're going to label them. But then they come back, and then eventually they show themselves to be a bipolar 1 patient. Okay? Then they go to subsyndromal depression. They're kind of down, dysthymic, you know, quasi, without being depressed, and they're depressed. And then they come back and they're hypomanic, and they go here. So they have multiple variations over time. But once you have mania, you're bipolar 1. That's it. One episode, that's the diagnosis that trumps everything else. Okay? Now, just to get ahead, if you never have mania, but you have hypomania, and if you had depression and hypomania, then you're bipolar 2. We'll get into the distinctions beyond here. But once you have mania, bipolar 1, if you've had hypomania and depression, you're bipolar 2. And that's the distinction. Okay, let's look at bipolar 2. Now they'll kind of set the stage for what that looks like. Okay. To have bipolar 2, I already told you, you have to have the following criteria. One current or past hypomanic episode, not manic, hypomanic, and I will define that here shortly, and the criteria for at least one current or past major depressive episode. So bipolar 1 is just mania. You don't have to have depression in your background to actually be diagnosed as bipolar 1. As soon as you have major depression and hypomania, you're bipolar 2. If down the road you ever have a manic episode that meets criteria, then you're bipolar 1. And it stays that way for the rest of your time. So major depression over here, as soon as you have mania, And if it's hypomania, then you're bipolar 2. If it ever ends up being a manic phase, then you're bipolar 1. And that's kind of what the pieces are of the puzzle. There can never have been a diagnosis of manic episode. You can never be diagnosed as bipolar 2 if you've ever had a manic episode that met criteria. That makes you 1. Okay. Bipolar 2 is similar to 1, except the patient experienced an episode of hypomania rather than mania. So I think we've got that out. The patient must experience a distinct period of abnormally and persistently elevated, expansive, or irritable mood. This is always your lingo. Elevated, expansive, or irritable mood, and abnormally, persistently increased activity of energy, lasting at least 4 consecutive days. So, mania is 1 week. Hypomania is 4 days. Doesn't sound like much, but let me get the rest of the criteria out. To be hypomanic, be bipolar 2, 3 of the following must be present. And you have to have 4 if the mood is only irritable. So you're always looking at that mood. Are they elevated, expansive, and irritable? Or are they just elevated, expansive, and not irritable? They're just jocular and fun all the time. They never get snappy. Because if they're irritable only, then you have to pick up 1 more criteria. And it's the same ones that we talked about before. The inflated self-esteem, decreased sleep, or talkative. So it's all the same ones as before. The change has to be uncharacteristic of the individual. It's kind of a duh statement, but diagnostically, you can't have been, they're not just an irritable personality type. The episode, now this bullet point is your most important distinction for diagnosis. It is not severe enough to cause marked impairment in social or occupational function or to necessitate hospitalization. So they've had this 4-day episode of elevated mood, increased energy, and then they have some of those other characteristics, but it is not enough that they are impaired so that they don't go to work, don't go to school, can't go to work, can't go to school, don't need to be in the hospital. In fact, some of those people just have so much energy that people want them on their team because they can do a lot of stuff. They pull a lot of stuff off. So a lot of people that you see that you think, or how do they do that, they might actually be hypomanic, and it kind of gets to be a joke and you're going around, oh, I guess he's just hypomanic, kind of making fun of the energy levels. So it doesn't impair. If there are psychotic features, the episode is by definition manic. So if they are hearing things or seeing things, then they're manic, then they're bipolar 1. If they don't hear and see things and they're not impaired, then they may be bipolar 2. The episode cannot be attributed to physiologic effects of a substance or any other diagnoses. Then you have a criteria for hypomania. Okay, what does it run like? Okay, mean onset, mid-20s. It usually begins with a depressive episode and is not recognized as bipolar 2 disorder until the hypomanic episode occurs. That's why I showed you that timeline. If you saw the depression, you call it major depressive disorder, and then over time they eventually manifest. If they manifest with hypomania and they had this past history of depression, then they're a bipolar 2. If that mania goes to the level of mania, not hypomania, then they would be bipolar 1. Okay. Anxiety, substance use, or eating disorders may also precede the diagnosis, complicated detection. These people have fairly complicated lives, and you just kind of think, why can't you get your act together? There's just a lot of stuff going on in a bipolar 2 person. Many experience several episodes of depression prior to the first hypomanic. So if they had depression, that would be their medical record diagnosis until you finally saw the full expression of what was wrong in their brain. And it may not show itself early. It may take a while before you see what you have. That's why when you do mental health treatment, you kind of, everything, this is the diagnosis for now, but you might be presumptively thinking something else may happen, but you'll just observe and follow and monitor. That's why follow-up is really important.
Is it appropriate to educate the family on that so that the family could tell you when they're hypomanic if it only lasts 4 days?
Absolutely.
And then you could add that in their chart based off of family?
Absolutely. And one of the things that I think I've actually got a slide on this, is that you actually want other informants to help you understand what's going on. because hypomanic people don't tend to think there's anything wrong with it. It doesn't send them to the hospital or keep them from doing what they do. They just seem to be super people. So unless you have others observing, they may not have the insight that that's a problem, or they may not report it as a problem. They may figure that that's my best me and I like to be that way. And what's wrong with that? Okay, so it's hard for the person to always tell you the truth about what's going on, because honestly, in their experience, that might be fine. You know, they consider it sick in some way. Here we go. The number of lifetime mood episodes tends to be higher for bipolar 2 than for major depression or bipolar, which means that if you are bipolar 2, which means you've had major depression and you've had hypomania, you tend to have more episodes of one sort or the other over time. So there tends to be more instability in it, as opposed to major depression has its own instability, and so does bipolar 1, but that one tends to be even more so. The interval between mood episodes tends to decrease with increasing age. So the further you go, the longer you have it, the more you begin to see all the episodes come and go. So if you're a family member, somebody who has bipolar 2, it's really kind of a disease that wears people out. And a lot of times the families become estranged. We can't deal with you anymore. Because there will be criminal activity, sometimes there will be law, issues with the law, there will be broken family relationships, ugly behaviors that aren't forgotten, and then the people who don't have the mental disorder may be unforgiving. I mean, so it's just all of these things. So the disease is not just in the person, because it surely affects their life. All the people who interact with that also are affected. And we can't, you know, don't expect people to be able to handle stuff like that, because it's quite trying. You know, it's very difficult in a family. But family education is absolutely part of it, Taylor, and that's part of what, if a person gets hospitalized, that's one thing you do, is you try to educate the family about what things look like and how to interact with them. Okay. While hypomanic episodes define the diagnosis of bipolar 2, the major depressive episodes are more enduring and disabling over time. So it's really that depression that kind of takes them down and makes them non-functional more often than it's the hypomanic piece that goes in there. So there will be a lot of depression. To be hypomanic, you have to have major depression and hypomania. It's the depressed part that more often bothers them and is disabling, if you look at it over time. Despite the dominance of depression, once a hypomanic episode occurs, the diagnosis is bipolar 2 and never reverts to major depressive disorder. Okay? 5 to 15% of people with bipolar 2 have multiple mood episodes in the previous 12 months. As we said, those are rapid cycles. So it's not a large amount, but it's good enough. I mean, 5 to 15% is something notable. Switching from depressive episode to a manic or hypomanic episode may occur both spontaneously and during treatment for depression. This is one little treatment element you'll have to kind of hold in mind, is that if a person is bipolar 2, but they show up with depression, and you treat depression and not know that they're bipolar 2, some of the medications used to treat depression can actually precipitate a manic phase or hypomanic phase. So that's why being accurate in diagnosis is helpful, but in so many ways you can't really know or help yourself until it shows itself up. I mean, so that's why family histories are important. What's really happened in their life up to this? Can I be more suspicious of bipolar 2 than major depression, or am I not? You know, so it's harder to know. Okay. Okay. About 5 to 15% of individuals with bipolar 2 disorder will ultimately develop a manic episode, which changes the diagnosis to bipolar 1 regardless. So it's interesting, the vast majority of people who get diagnosed with bipolar 2 stay there, which is hypomania to major depression. That's their range in that continuum. But 1 in 10, 1 in 20 or 1 in 10 will finally have mania. And once they hit mania only one time, they're bipolar 1 for forever. Even though they may look like a bipolar 2 for most of their life, that would be the diagnosis of the chart. That's what would stick with them. Is all making sense? I think it does. I mean, it makes sense. It's kind of an interesting distinction, of presentations. And again, for probably a heterogeneous set of disorders in the brain, The diagnosis is the presentation. How does your brain, what defects in your brain exist, how do they show up in the diagnostic criteria that are established, and then that labels you a certain diagnosis and somewhat predicts how the treatment goes too. So what's the difference between mania and hypomania? Mania must exist for at least a week. Hypomania must exist for at least 4 days. Shorter duration. Severity. Mania is characterized by more severe symptoms, but the consequences are most important. Manic episodes cause more impairment, more consequences than a hypomanic. In fact, that's one of the diagnostic criteria that the hypomanic phase does not impair them. They still go to work, they still go to school, they still do stuff, but not so disruptive that people want to get rid of them. Misdiagnosing bipolar. The diagnosis often missed. Patients often fail to mention the presence of manic or more commonly hypomanic symptoms in a past or current episode. Screening bipolar patients when they present with depression is seldom conducted. You don't see most people take depression for depression without being suspicious that maybe this is the first manifestation of a bipolar disorder that will play out over time. 40% of people diagnosed with depression are subsequently found to have bipolar disorders. So that means almost half the people you see that you call depressed will actually end up being bipolar. Isn't that interesting? There's an average of 8 years from the time of first presentation until correct diagnosis in patients with bipolar disorder. So if you wait long enough, they'll eventually show themselves. It's interesting, probably, that some of the people who are bipolar, who come in as depressed, you think that's what they are, we probably throw them into hypomania or mania by the treatments that we have used. Then they're declared, and then they're diagnosed, and then you can do the rest of the treatments that you need. Consequences of misdiagnosing, a lot of things, behavioral issues can happen in your life. Suicide attempts are 25 to 50%. Suicide attempts are 30 times more likely during a depressive episode than manic or hypomanic. Hypomanic people don't tend to want to kill themselves, but they might want to kill you if you're in their way, if they're very irritable about everything. So misdiagnosis, leads to suffering, breaks families down, things like that. And also the use of antidepressants in bipolar depression, especially without the concomitant use of a mood stabilizing medication, may actually worsen the course of the disease. That's why fixing a diagnosis is helpful, because treating bipolar is much more difficult than treating depression. Depression tends to be, a drug and maybe anxiety medication if you have depression, anxiety. In bipolar, you have to have mood stabilizers, anti-anxiety drugs sometimes, and antidepressants. They tend to be clusters of drugs, not just single drugs. Antidepressants, as they have been shown to contribute to rapid cycling. Okay. Now, let me just give you two more terms that we have that I haven't used, just kind of phraseology. Distinction between unipolar and bipolar depression. Unipolar depression is just major depressive disorder. That's all you have. You're on the low end, the depressed mood. That's unipolar. When you have depression, then you go to hypomania and mania, then that becomes a bipolar depression. It's just indicating that in that person, their mood presentation runs a spectrum. If you're unipolar, their mood spectrum is normal to depressed, and if they're bipolar depression, they're depressed to hypomanic or manic. Okay, just a little bit more. Depressed patients, Taylor, here's the answer to your question specifically. Depressed people with type 2, bipolar 2, are more frequently misdiagnosed than those with bipolar 1 because the patient often feels well with hypomanic and may not report them even if questioned directly. The patient does not present with psychotic symptoms, therefore they're not hospitalized, so there are no records of a hypomanic episode in their past. And the clinical presentation of patients with mild hypomania may be irritability rather than euphoria, or they may report an exaggerated sense of well-being that is often associated with an elevated mood state and not hypomania. They're just excited, happy, and not called hypomania. So because of its presentation, it doesn't look that far out of normal necessarily that they think it's something wrong, or even the clinician seeing them thinks it's something wrong. But in the context of major depression, you begin to look at that thing with a little bit more of a slanted eye. 35 to 60% of patients with bipolar disorders may experience an episode of major depression before experiencing a manic episode. So again, a lot of people are going to go on towards that. The presence of a hypomanic or manic episode is required to establish the diagnosis of bipolar disorder, and until that sentinel event occurs, it is virtually impossible to diagnose a patient with anything other than major depression. Okay. This, you know, I've kind of hammered on this so much because it's a huge distinction to make is when you look at people who come with mood disorders, think the continuum and think about where they might show up and what kinds of presentations that might encompass so that you have a better chance of being more comprehensive in your assessment. And then as you know things, you can kind of lock it down. But if you come at it, oh, they're just depressed, don't come at they're just depressed. Think they're depressed, but where are they? What has been happening? So you have to look at it like this and not like that. Screening for manic and hypomanic symptoms, you can, I told you there was that form, you can use the mood disorder questionnaire. It's not often done, but it could be and should be. The mood disorder questionnaire is really the tool to use. So if I ask you on the test, if you're a primary care provider and you're looking comprehensively at a person and you're trying to figure out whether they might be a bipolar person instead of just a unipolar depression, what instrument would be most useful? Well, it would be this one, because this one asks the questions to distinguish mania and depression, or at least to pick it up. It's very short. You can look at the questionnaire, one-page questionnaire, 13 yes and no items. The patient can do it. There's 2 additional questions regarding function and timing of symptoms. If they get 7 or more yeses, then they are with a yes on question 2 and a response of moderate or serious to 3, then they're a positive screen. It's a pretty sensitive screen. It can be done in 5 minutes or less if you're literate. So just take a look at that form and see, but it's very useful in screening. And again, it will help you in a primary care practice because it's quickly done. You'll be hard-pressed to be able to do it in less than 5 minutes with that kind of accuracy. So those kinds of tools are more helpful in getting to the point, because to start asking all the questions is going to take you forever with all the answers. You just need to check boxes, and that will help you get it done more speedily. Interviewing a family member or other informant, you do that. Attempt to interview the spouse, parent, child, significant other, close friend. They may fail to recall it or not report it. They may fear stigma of being associated with bipolar disease. So we've talked about that, but you do want to look at other members to help you know. Okay, let's look at physical exam. Let's look at the appearance. Depressed episode is the same as what we looked at for depressed episode for major depressive disorder. I'm not going to have to go through all of these because you can look at them, but poor, unkempt, poor grooming, depressed affect, slow movement, psychomotor retardation, speaking in low tones, all of those things remain the same. If they're hypomanic, let's look at what does hypomania look like compared to mania. They're busy, active and involved. If they're hypomanic, energetic, on the go, planning and doing things. Others notice their energy levels and mood changes, and they're often rewarded for it. Okay? Manic, okay, here's more. It's a behavior opposite the depressed phase. They're hyperactive and hypervigilant. That's why if you laugh at them, they're taking you in like this. You know, you're doing stuff and they're just measuring a response. So they hear your comment, they interpret your comment and just come back at you very rapidly. They really actually are responsive in time more rapidly than other people, and it's somewhat kind of unnerving because they almost seem to be super powerful. Like that woman, she was measuring stuff up pretty fast, and I think if you rattled her cage or poked at her, you could just blow her up. I mean, I think she is an easy blow-up target because she was so reactive to things. And she was funny and laughing, but I think she could go at you too. Her husband's like, I beat him up. Well, I want him out. Slap the shit out of it. You know, she was like, I'm gonna get you. So they're restless, energized, active, talk and act fast. Clothes are usually put on in haste and disorganized. They wear bright clothes. Seriously, I mean really bright stuff. You know, hot pink, orange, yellow, just out there. They stand out in the crowd because their dress attracts attention sometimes. Okay, let's look at affective mood. That was appearance. So you know depressed, Hypomanic is kind of in the middle, and then manic is the far out end. Depressed episode, affected mood, sad, lost, vacant, isolated, the two H's, hopeless and helpless. Hypomanic, mood is up, expansive, often irritable, but not necessarily interpreted as unacceptable in society. Then manic, inappropriately joyous, elated, or jubilant, euphoric. Annoyance and irritability, especially if mania has been present for a significant length of time. Early on, they're more euphoric. As time goes by, they tend to be more annoyed with folks and things. Let's look at thought content. In depressed, is what we said yesterday, sad, glasses half empty, glasses 2/3 empty. Focus on death and morbid, they're focused on death, they're morbid people, they may think about suicide. Hypomanic person, look at how they present in thought content. Optimistic, forward-thinking, positive attitude, we can get things done. But manic thought content, very expansive and optimistic thinking, excessively self-confident and or grandiose, rapid production of ideas and thoughts. They perceive their minds as being very active. They perceive themselves as highly engaging and creative. Highly distractible and quickly shift from one thought or topic to another. So in some ways, if you have them on a topic you don't like, you can redirect, like with a child, you give them another toy, show them something different, you give another idea and they kind of go with that, and you take them off of the area that you want to get them off of. Let's look at perceptions. What does a depressed person perceive? A bipolar depressed person perceive? Delusions of having sin, okay, the delusion of sin, guilt, remorse, what they've done. They're worthless and they should live in total deprivation and degradation. Some persons have paranoia and or persecutory delusions, significant depression. Okay, hypomania, they do not experience perceptual disturbances. So hypomanic person is just high functioning. They don't perceive things differently. Manic, 75% of manic people have delusions. That woman had the voices thing. She also had both sex organs, which I think is probably a delusion and not reality. She could make the weather work. I mean, she had these powers from God that because she was the secret agent, the spy, you know, she could do stuff. And could you do it right now? Oh, of course I can. She had it. She was down. So delusions of power, prestige, position, self-worth, and glory. Well, this woman had set herself pretty high. I mean, she could do some stuff. Okay. Let's look at where they are in terms of suicide and self-destruction. Depressed episode, higher rate of suicide. So you need to determine if they have thoughts of hurting themselves or plans to do so. The more specific the plan, the higher the danger, which is true for all depressed people. And as patients emerge from depression, suicide risk increases. That's true. You know, that's the one big thing you worry about when you're treating depression is that once you start treating them and their energy level starts to come up, they may still have thoughts and plans for committing suicide. So a lot of suicides happen once they've partially been treated. That's one reason why a lot of people will not give refills on antidepressant medications because they want them back. So the first fill might be 15 to 30 days, maybe 15 days because I want to see you, because you need to know where they are, because they will overdose on their medication. And it was particularly a problem back when tricyclic antidepressants were used because TCA overdose was fairly common. So you kind of treat them, they got these multiple refills, go to Walmart, get 90 amitriptyline, take a week's worth, have the energy, take the rest of them, dead, cardiac arrhythmia dead. So hypomania, the incidence of suicide is very low because they think well of themselves. They wouldn't destroy themselves. They're optimistic. The future is theirs. And manic incidence of suicide is very low because they have all the power. Why would you kill yourself? You can do anything. I can direct weather. You know what? So they don't. Homicide, violence, and aggression. Let's look at this. Depressive episode, suicide, your big fear in a depressed person who's bipolar. However, some see the world as hopeless and helpless for themselves as well as others. This perspective can lead to homicide followed by suicide. A depressed person, if they had enough energy, could kill all their children themselves. I mean, you've seen these stories on the news which just make you sick, is that the mother killed herself. It might be postpartum depression where she does that, has the energy. Kind of scary. So that's depressed. Hypomania, where are they in the homicide, violence, aggression spectrum? Frequently show evidence of irritability and aggressiveness, pushy and impatience with others. So that's their aggression. I don't know that I call it violent necessarily. Manic, openly combative and aggressive. She beat her husband up. No patience or tolerance for others. Demanding, violently assertive, highly irritable. Homicidal element emerges if they have a delusional content to their mania. What if God had given this woman power to get rid of all the sinners on the world? Then when she had that energy, she could kill somebody. Act out their grandiose belief that they must obey their command, wishes, and directives, and the delusions become persecutory. If they become persecutory, they may defend themselves in a homicidal fashion. What if the voices talking against her in the hospital were perceived as threats to her, and she had the opportunity and the weapon, she could maybe kill people before they got hurt, if she thought they were out to get her. Judgment and insight, what does this look like? Depressed people, they don't have judgment, it's dim, it's clouded. They fail to make important actions because they're so down and preoccupied with their own plight. No tomorrow, planning is difficult, forgetful, sometimes they have little insight into their own behavior. So judgment and insight is very down in a depressed person. Hypomanic is actually pretty good, but they have expansive judgment. They can decide more things for more people because they have more insight, they're bigger. They take on too many tasks, they can become over-involved. Distractibility can impair judgment. Little insight into their driven qualities. They see themselves as productive and conscientious. And really kind of better than. Judgment and insight in a manic episode, the hallmark is seriously impaired judgment. Did y'all think that woman had good judgment? I mean, she was really kind of out of touch with reality in almost every way you could look at it. Terrible decisions regarding work and family. Beating up a husband is probably not good, but we don't know what he did to her. Nothing wait and see. May invest family fortune in questionable funds. One of the diagnostic features is that bad decision making. They don't listen to feedback or suggestions or advice. No insight into the extreme nature of their demands, plans, or behavior. Commitment proves the only way to contain them. And so sometimes when they're so out of control, and that's how the family was, they're so out of control, you have to commit them, because if you don't restrain them some way, they could hurt themselves or hurt other people. Differential diagnosis is very similar to what you're looking at when you're doing depression. You're looking for anxiety disorders, Cushing's, you're looking for hormonal problems. Do they have a head trauma, thyroid issues, PTSD, schizoaffective schizophrenia, lupus, medications, ADHD, a lot of things for them. So the differential is wide, even wider. I'm just giving you it's a full range of anything that can create a behavioral disturbance that you learned in neurology, because almost all of them have behavioral disturbances as a manifestation. Lab work, some things you look at in some of the rationale, some more of this, you'll get some of this in pharmacotherapy shortly. Anemia is a cause for depression. Anticonvulsants can suppress bone marrow. You talked about the RA. Lithium, which you'll look at, causes reversible increases in white blood cell count, so you have to monitor. SIB rate, you look at for infection or lupus. Fast, glucose for diabetes, and we're going to focus a lot on metabolic disturbances from major antipsychotics that are used in bipolar disease, because it is a huge problem right now in the whole field, is that these antipsychotics can cause several metabolic derangements, weight gain, diabetes, dyslipidemia, the increased risk for cardiac disease. So our treatments to stabilize mood can create complications that can actually shorten life. And so you have to really start paying attention to what are the major adverse effects of the treatments that are available. Electrolytes are looked at for metabolic sources, calcium, serum protein, don't worry about those. Thyroid, substance screens, urine copper for Wilson's disease, very rare. ANA, HIV, VDRL for syphilis. Again, it's all the range of things. Treatment. Okay, overview, just big overview. Referral or close consultation with a psychiatrist must be strongly considered. This is probably not a patient type you want to manage in a primary care practice alone. I think you're gonna have some that you take care of for other problems, but psychiatric problems, you probably need somebody who is more aware and more tuned into the nuances of treatment for them. Drug therapy is more complicated and involves greater risk than when you're just treating a major depression, a unipolar depression. Polypharmacy is a rule. They're usually on more than one medication. Lithium has been the standard of treatment for decades and still has a place. There are anticonvulsants that are used. There's some anticonvulsants with mood stabilizing properties. You'll see that valproic acid, divalproex, carbamazepine, and lamotrigine. Those all have mood stabilizing benefits. And then atypical antipsychotics, the olanzapine, Risperdal, those type of agents also. Inpatient hospitalization is very important for these people in the manic phase. Patients who are in danger of the self, others, unable to function, and with out-of-control behavior. They also need medication monitoring just to get them introduced and stabilized, because if they're not stabilized, it's hard to let them get back out. So they need structure and stabilization and monitoring with their medications before they can then move out. There are some partial hospitalizations or day treatment programs. It's not for everybody, but for the people it's been useful for. They have severe symptoms, but with a reasonable level of control and with a stable living environment. So if a person has some sense of control and they have a good supportive family environment, then you might be able to pull off day treatment, and you do see that. But if they really don't have good family situations, it's harder to do that, and that is true for a good number. Your outpatient treatment goals, there's 4 things. Establish the way to manage areas of stress in life. They usually have many things going wrong and don't know. See, I didn't touch anything. Isn't that weird? Okay. They have stress in life, and this helps them decide how to manage stress. So there's that counseling part. Stabilize medicines to get benefit without adverse effects. You want to develop a therapeutic relationship, so whichever psychiatrist or provider's taking care of them, they need to know them very well, and that person needs to know them, because their story and their behaviors and how they show up is very important. And if you've not seen that all along, it's just very difficult, like any patient, to see them for one time. Is this normal? Is this out of the range? This is an odd delusion. Some of those stories are the same over time. So they need that continuity is very important. And then you want to educate the patient and family about the disease and the dangers of substance abuse, relapse, roles of medicines, and support groups. There's usually a lot of things going on in and outside the legal system, besides in and outside the family system. Medication, the appropriate medication depends on the phase of the disease. Are they depressed? Are they hypomanic? Are they manic? What are they showing? What are their symptoms? And so the symptoms, psychotic features, agitation, aggression, sleep, all of those things dictate how your treatments are picked, but that's going to be covered in the next 2 hours, the details of that. Prognosis, bipolar 1 is far worse than those with bipolar 2. That's the people who have mania, the extreme mania. Within 2 years after an initial diagnosis of bipolar 1, 50% experience another manic attack. Factors suggesting the worst prognosis: poor job history, alcohol abuse, psychotic features, depressive features between periods of mania and depression in the male sex. A lot of people, there really is quite a lot of drug abuse within the population, so that's just another factor. Better prognosis: manic phases are short in duration, later age of onset for disease, few thoughts of suicide, few psychotic symptoms, few medical problems. Okay, our conclusion. Very serious group of illnesses, very difficult to treat, kind of difficult to get the diagnosis in place as you kind of work your way into it. Associated with a lot of morbidity and mortality. Treatments for unipolar depression and bipolar depression are very different, because you have to get mood stabilization in there too, as well as antidepressant therapy. And consider the differential diagnosis of bipolar to be a routine part of working up any patient who comes in with depressive symptoms, so that you don't miss it and inadvertently cause mania or hypomania by your treatment for depression as if it were just unipolar depression alone. Okay? And I think that's it. Kind of wanted to get y'all out so you had at least 10 minutes to kind of breathe. Any questions about this spectrum of diseases? Major depression, hypomania, mania, cyclothymia, rapid cycling. But what I want you to be able to distinguish is major depressive disorder from dysthymia versus hypomania, bipolar type 2, versus mania, bipolar 1. If you can operate with that understanding in to make the distinctions, then the treatment begins to make sense beyond that, and you'll be in pretty good shape. Okay, any questions? It's a lot of stuff, but it's not a lot of stuff. You'll let you have a chance to look at it. Okay? Take a break.